And we are very pleased and appreciative of the opportunity to talk tonight with Dr. Michael Klompas, who is an infectious disease doctor at Brigham and Women's Hospital and a professor at Harvard Medical School. And he's here to help us understand more the different issues with the health and safety concerns of school reopening and answering the questions that we know that many of you have as you're trying to make the decision about what's best for your child and your family. We're joined also with folks from Mass Advocates for Children with Lilia Malikshi and Joanne Pino. Lilia will be reviewing all the questions that she tells you how to post in a minute and asking them of Dr. Klompas after he gives his initial presentation. We know there continues, there's a poll now, just so we know what kind of disability your child has while we're going through these housekeeping things. We know that you continue to face so much uncertainty about what's going on in your school district. We know there's a few schools that are opening now, but most will be opening in some way in 2 weeks. And many of you are still waiting to know what that means. Will your child be remotely learning from home full-time, at least at first? And what will that look like? Will they be able to be in person for part-time or full-time? There continues to be so much uncertainty for families and for educators. And Dr. Klompas is here today to help answer questions about what we know is one of the hugest concerns for families and students, as well as educators and community members about the health and safety issues. So, Lilia, you want to finish up the housekeeping and then we'll turn it over to Dr. Klompas?
Sure. So thank you everyone for joining us, whether you're on Zoom or on Facebook. Tonight we'll have our Q&A session after the presentation ends. So please submit your questions at any time using the Q&A button on the bottom of your screen if you're joining us on Zoom. Those of you joining us on Facebook, hello, please submit your question as a comment under the live stream. Our MAC volunteer extraordinaire, Christina Perez, will be there to facilitate your Facebook comments. So thank you, Christina. And if you see someone else's question that you'd like us to answer, please be sure to give it a like. And also, whether you're on Zoom or Facebook, keep an eye on the chat box on Zoom and the comment section on Facebook for resources that we'll be sharing throughout the presentation. Thank you.
So I am thrilled to turn this over to Dr. Klompas, and thank you again.
Okay, thank you so much. So I really appreciate the opportunity to be able to speak to you today. I'm going to be sharing you some thoughts and some data, what's happening with COVID-19 in the US and in Massachusetts in particular, some thoughts about what we have come to learn about the transmission of disease and the risk of disease in various kinds of young people versus old people. I think there's more I don't know than that I do know. Like you, I have kids myself, and my wife and I wrestled mightily with the question about what to do about school. Maybe I'll talk a little bit more about our thinking later on, but I certainly don't have the answers. I'm struggling to sort of make my way through these very real dilemmas with you. But let's go on. So, working here, there we go. So as you know, this outbreak was first characterized in China in the city of Wuhan. It was initially associated with a cluster of severe respiratory infections associated with this live animal and seafood market in the city of Wuhan. But it rapidly spread around the world to Italy, South Korea, this is Iran, Thailand, and of course the United States. We're at the point now where there are over 26 million cases that have been documented worldwide. They're probably at least 10 times more than that number and getting close to 900,000 deaths. The real hotspots in the world right now in terms of the number of cases per day relative to the size of the population is still the USA, much of South America, and a resurgence that's taking place in some parts of Europe, particularly in Spain and France. Within the United States over here, this is also looking at the number of new cases per day per 100,000 people. And you can see that still the greatest occurrence of cases in our country is still taking place in the Southeast and increasingly so in the Midwest. If you look up to the northeastern part of the country where we are, we're in the yellow zone. Much of Maine is in the green zone. So we're doing a lot better than a lot of the country. Not quite as good as our friends to the north in Maine, but still pretty darn good compared to many others. If you look at that by case counts per day in Massachusetts, we're substantially lower than where we were at the height of our particular outbreak, which was, of course, in April and May. At that time, we were experiencing on the order of 2,000 to 2,500 cases per day. And then with all the measures that we all took to try to contain that, the social distancing, the closing of schools, the closing of businesses, the wearing of masks, the distancing, the hand hygiene, so on and so forth, we were collectively able to drop the number of new cases per day in our state down to around 200 cases per day. As society has reopened, I think on a scaled and thoughtful basis in Massachusetts, there has been some increase. So we've gone from about 200 cases per day to up to around 400 cases per day. We're still substantially lower than where we were back in April, and only a little bit higher than where we were in July. And the good news, we've been able to maintain that level of around 400 cases per day now for almost about a month. So we have some stability despite the ongoing opening of society. I think it's really a testament to the public health action that's taken place over in our state, as well as some of the many ongoing measures that we're all still embracing. So the closing still of indoor dining spaces beyond a certain size, the encouragement of distancing, the encouragement of spending time outdoors, the encouragement of masking, so on and so forth. You can see it still is having a positive effect for our state. And if you look at, now, I know there's a lot of controversy around testing and this idea that's out there that maybe our case counts are being swelled by too much testing. And so a way to get a more sort of reliable gauge as to what's actually happening is to not look at testing, but actually, or positive tests overall, but look at people being admitted to hospital. And the good news over there is this is showing the counts of total cases and admissions at all the Mass General hospitals, Mass General Brigham hospitals, that's the former Partners Network. And you can see that while there was a spike in total cases and admissions back in April, May, things have been pretty flat. Despite the small increase in overall case counts, the number of admissions to hospital has remained pretty steady. People also talk about the percentage of tests that are positive as a proxy for how much disease is going around society. So over here in the Mass General system, back in April, May, about 25% of people we were testing were positive, and now it's down to around 1%, which again on the national scale is a pretty good level. Now, of course, things are not equal by community. It does vary according to where you are within the state, and there's much more disease in the eastern part of the state compared to the western part of the state. And even within the greater Boston area, the real cluster of disease is taking place in the North Shore, around Lynn, Revere, Winthrop, and associated communities. This really matters as to the local disease rate in your community, because when we think about the safety of going back to school and the possibility that somebody's going to get infected in school, it really has to do with how much disease is floating around that particular community. And so I encourage you to take down this web link over here that's inside this slide, and you can check this out for yourself. This is updated by the state on a regular basis. You can hover over any particular county, and it'll tell you if you're in the green, yellow, or red zone. And I would be more circumspect about going back to school in the red zone. I'd be more comfortable about going back to school if you're in the green or the yellow zone, although of course there are many other factors to take into account. Now, things again are not only unequal by community, they also differ by race, ethnicity. And as we've heard throughout this epidemic, this has had a disproportionate impact on people of color. This is the percent tests that are positive depending on race, ethnicity, and you can see that it really continues to be the Black and Hispanic communities that are disproportionately likely to be positive. How about if you look at the age and sex distribution? And this is looking at new cases in the Mass General system, Brigham system over the past month. And you can see over here by age group that the predominant people that are getting infected at this particular phase of the epidemic is young people. That's different from back in April, May, where the predominant number of people being infected were older people. And that actually accounts for why mortality rates were much higher back in April, May, because of the disproportionate impact on the elder population. You can see now that the greatest number of people being infected is in the under 40 age group. Maybe that reflects, I think what we've all seen in the popular media is that this is the age group that is more likely than others to be maybe a little bit more, a little less intense, I guess, with their masking, more likely to go to social events, more likely to be sharing meals together, and that I think is reflected in the higher case counts in this group. There was a notion earlier on this epidemic that children are spared, that sort of the youngest of the young will not get this infection. That's clearly wrong. And I think what we are seeing in the past month or two is an increasing number of the youngest in our society, people under age 20 and under age 10, that are being infected. And that's partly reflected in this figure here as well. In terms of disease severity in children, the message that you've all heard is right, that most children do perfectly fine. So here's a characterization of disease severity across 91 children in South Korea. They were identified through either because they were traveling into the country and therefore were tested per force, they were contacts of people who are known to have COVID, or if they actually developed symptoms. And about 22% of the kids in this particular series had no symptoms whatsoever, so completely asymptomatic. And the majority, 51%, so half of the kids, had just very mild symptoms. Nothing worse than what you would characterize as a normal cold or flu. About 22% in the series had moderate illness, so kids that were a little more sick, and only 2% had severe disease. And as we know, deaths in children, thankfully, are extremely rare. They have occurred. So I think when I was last took a look at United States wide, across the entire country, there have been 300 deaths thereabout in people under age 20. Okay, so each one of those is an absolute tragedy. I mean, it's difficult to even wrap your mind around what that's like. But on an overall national scale, that is a small number, and it's actually fewer than the number of flu deaths that occur in the child population per year. Again, that's not to minimize it in any fashion, but rather to give some sense of perspective. If you look here at mortality rates, this has been difficult to estimate because of the problem that we only test only a fraction of people who probably have the disease and therefore underestimate it. But this particular study comes from an analysis in Indiana where they did statewide antibody testing on people and were able to correlate that with their mortality rates at around the same time. So this, I think, is a much better read. If you look here to the far right in purple, you can see the overall mortality rate across the entire population was 0.25%. So about 1 in 400 people who get this disease, unfortunately, succumb to it and pass away. But you can see here that the risk really varied substantially by other characteristics. So older people clearly continue to be those who are most likely to have bad outcomes from this infection. You can see amongst those over age 60, mortality rate just under 2%. By contrast, those under age 40, 0.1%, so 1 in 1,000. As before, there is a disproportionate impact on people of color. You can see over here that the overall mortality rate in non-whites is 0.6% versus 0.2% for whites. This is something we've seen again and again, that men are more likely to have bad outcomes from this disease compared to women, although you can see overall the rates continue to be, or the mortality rate is very low. Let's shift gears a little bit and talk about transmission. I mean, what do we know about how this disease is passed from one person to another? So let's talk a little about what we know about that. So the first factor is the incubation period. The incubation period, you'll remember, is the time period from when you first are exposed to the virus until you develop symptoms. And on average, that turns out to be about 5 days. The range turns out to be between 2 and 14 days. Most people will be infected within 12 and a half days. But again, the average is around 5 days. So after you get exposed, 5 days later is when we expect that you are most likely to show your symptomatology. Now, you've probably heard that one of the very difficult or challenging things about this infection is that people are contagious even before they develop symptoms. And you might wonder how it is that we know that and how we're able to quantify that. And forgive me for being a little bit sciencey over here, but I think this is amazing. And so therefore I want to share it with you. Feel free to tune out if this part's a bit too technical. But what you do is you take a look at a person who has infection, and we know that they have their incubation period, and we've seen across the population that turns out to be at 5 days, and then they develop their symptoms, right? That lasts for some period of time. Now, what you can do is sometimes you can identify a clear series of one person who passes it to another, and you know who both those people are, and you can work out then how much time from when person A got their symptoms until person B got their symptoms. So we can find our second person over there, they got their symptoms a few days later. That gap, that period of time, is called the serial interval, and you can work that out over a number of these pairs of infections. But what you can do is once you have that serial interval, you can put onto the second patient over there their incubation period, right? Because we know the incubation period is typically 5 days. And what you end up with is with this overlap period over here, where this person's incubation period overlaps with this person's incubation period. And that's the period of time during which the first guy was contagious without having any kind of symptoms. And if you do that to a population, you'll see something like this. And it turns out that you are contagious for about 2 to 3 days before you develop symptoms, and your contagiousness thereafter rapidly drops off. And by about a week after you develop symptoms, you are no longer contagious at all. So can we quantify this? How contagious is this disease? I know that when I was first reading about this disease and seeing the dramatic stories coming out of China about Wuhan back in February, I mean, I had the impression over here that this was an incredibly contagious disease, that you so much as looked at somebody the wrong way who had COVID and you were going to get it. And it turns out that's completely wrong. And we know this from intensive contact tracing studies of people who had confirmed COVID. So the way this works is you identify people who have confirmed disease, and then you ask them to identify every person with whom they had close contact. Close contact is usually defined as being within 6 feet of that person for more than 15 minutes. So these are pretty close contacts. And so in this particular study over here, they identified 147 people who had confirmed COVID, and they identified about 2,147 close contacts. Now, of all those contacts, 6% got infected. Okay, so take a pause for a moment over there and just reflect on that number. 6% of close contacts, 15 minutes within 6 feet of the case person, only 6% became infected. I actually find that a pretty reassuring kind of a number, because again, if you had that impression like me that everybody who came close to someone with COVID was going to get infected, this tells us that's wrong. Actually, only 1 out of 20 people in contact with someone with COVID is going to get the infection. However, the risk varies substantially by the nature of your contact. It turns out that the likelihood of infection is very much related to the duration and the intensity of contact. So it won't surprise you then to learn that the people who are at highest risk of catching COVID from somebody else are household members. And you think about the way we operate in our homes, we spend lots of time together, we're often very close together, we share meals together, we hug, we kiss, etc. And so there are lots of opportunities for very close contact. So amongst household members in this particular series, 18% got infected. Those people sharing a meal, 7%. Relatives, 5%. People who simply were shopping together, less than 1%, about 0.6%. Here's another study taking the same approach and doing a similar sort of quantification, very similar sorts of results. Analysis of 3,410 close contacts of 391 COVID patients. They identified the close contacts over here through cell phone tracing by looking to see whose cell phone was close to another person's cell phone for a sustained period. So actually this was very rigorous contact identification. And as with the prior study, of all the close contacts, only 3.7% became infected. So again, the majority of close contacts do not get this infection. And as before, that attack rate, the infection rate amongst those close contacts varied substantially by setting. In this study, household members, 10% became infected. People who were in the same entertainment venue or workplace, 1.3%. People who sought healthcare, 1%. People who were on the same bus or subway together, 0.1%. And again, those were people within 1 meter, in this particular case, of a person with confirmed disease. So again, the context of your contact really matters. Now, how long are people contagious for? So we have good data on this as well. This comes from a contact tracing study in Taiwan, where they added on the extra twist of saying, what was the likelihood of a contact becoming infected, depending on how long the person they'd been in contact with had been sick. So it turns out that the more time since your symptoms began, the less infectious you are. So if you were in contact with somebody on the first day they developed symptoms, you had a 1% chance here of getting infected. If you were in contact with somebody who was in 1 to 3 days after their symptoms began, still a 1% chance of getting infected. But by day 6, after symptoms started, the contagion rate was 0. So again, bringing home the point that you're only contagious for about a week after you develop symptoms, and therefore it rapidly drops off to almost nothing. This is do the same analysis, just looking at household and family members. No surprise over here that the overall attack rate amongst close contacts is much higher, so 4% here compared to 1% amongst all contacts. But again, by day 6 and beyond, the secondary infection rate dropped down to 0. So you no longer are contagious after about a week. You can compare that to other kinds of diseases. The figure they use to quantify is something called the R0. The R0 says, what's the average number of people infected by each case? So for COVID over here, the average person with COVID will infect between 3 to 5 people. That's more than flu, which is each flu person infects about 2 people, and substantially less compared to things like chickenpox, whooping cough, and measles, where that number of people infected by each case can range from 10 to even to about 20. They're giving you some context. Bringing home the idea that COVID actually is more contagious than flu is an amazing sort of bit of data emerging from the Southern Hemisphere, where, as you know, they are in their winter right now. And the question is, what's happening with their flu during their traditional flu season? And here's the amazing thing. Despite the fact that in the Southern Hemisphere, they are still seeing plenty of COVID. You'll remember our very first slide showing the rates of disease by worldwide and the very large amount of disease in South America. Their flu rates have gone down to essentially 0. So that's a remarkable thing. Meaning, I think, that all the things that people are doing to prevent COVID, so wearing masks, distancing, hand hygiene, cleaning, all the rest of it, has been enough to completely eliminate flu, but only partially bring down COVID rates. The message being, therefore, that COVID is more contagious than flu. Now, the likelihood of somebody becoming infected also varies depending on how sick you are. So the sicker you are, the more symptoms you have, the more likely you are to spread COVID to others. So this is good news, because again, we've been talking here in the context of children who are most likely to have mild disease. So even if a kid does get infected, not only will they most likely have a mild experience themselves, but they are less likely to pass it on to others by virtue of having asymptomatic or mild disease compared to an adult who's more likely to get more severe disease. This, by the way, also brings home the critical importance of staying home if you are sick. Because if you are sick and you actually have symptoms, you're more contagious compared to a silent carrier, compared to an asymptomatic carrier. And that's why so many systems are putting such a strong emphasis on making sure anybody who has any symptoms, those people really need to stay home and self-isolate. Now, getting more into how things might vary in children compared to others. So here's an analysis of 60,000 contacts of almost 6,000 people with COVID in South Korea. Focus yourself over here on the red, first of all, which is people in houses. And you can see over here that while the household contacts of adults is high, and it gets a bit low as people get younger, nonetheless, in the teenage group over here, the attack rate for kids who are infected actually is quite high. And this was a study that really told us that this notion that teenagers or kids are not contagious is actually wrong. It's clearly wrong for teenagers. There's still some debate about kids under age 10, that maybe they're a little bit less communicable compared to teenagers. I have to say that I'm not clear myself if that's actually true. Although that claim has been made, it's difficult to interpret data like the one I'm showing you, because the behavior of kids under age 10 has not been normal over the past few months, right? They, like us, have been isolated at home. Their number of social contacts has been limited. And knowing who gets infected first inside a household is actually difficult to do because of the fact that so many kids are asymptomatic. So I would take with a grain of salt the notion that kids under 10 are less contagious. Might be true, but just as likely, in my opinion, that they're just as contagious as anybody else. Okay, let's look a little more about the actual mechanism then of contagion. Now, we know that the primary way that COVID-19 spreads is through respiratory droplets. And this over here is showing a figure of a person who's talking, coughing, sneezing. And you can see they're emitting a range of respiratory secretions. Now, the secretions fall into 2 different categories. There are droplets and there are aerosols. Droplets are bigger little secretions that are big enough that they fall to the ground by virtue of gravity. They typically fall to the ground by virtue of gravity within the radius of 3 to 6 feet. That's where the magical 6-foot number comes from. However, people also have secretions that are aerosols, which are much smaller than the droplets, and are small enough, in fact, that they can remain suspended in the air and float in the air for sustained periods. Now, they can also carry virus, and they can also lead to people getting infected. So if the virus actually is able to remain suspended in the air, how come we aren't seeing more infections? You might wonder. And here's the answer. So here's a picture of a simulation of a person who is coughing, and this is using a laser to demonstrate those aerosols that the person's emitting. And you can see here they go out to 3 feet, 6 feet, 9 feet, 12 feet. Okay, so it goes beyond our 6-foot classic limit over here. So keep that in mind. But the other thing to notice, of course, is that the density, the amount of aerosol rapidly diminishes over time as a function of dilution. Think of it as somebody who is, say, smoking. The further you are away from that person, the less and less dense that smoke becomes. So the same thing with respiratory secretions. The further away you are, the more diluted it is by surrounding air. And so I think what happens in practice is that although that air might contain aerosol with virus, by virtue of just distance and dilution with non-infected air, the amount of virus gets below the critical threshold that causes infections in most cases. There is one exception that I'm going to tell you about shortly that's very important. And that's this, which is that, as we know, there's this big issue with ventilation. So let me tell you what the issue with ventilation is, which is that under normal circumstances, if somebody is emitting some of those aerosols, it will be rapidly diluted by the surrounding air with a function of time as a function of how far away you are from the person. The exception, though, is if you're in a poorly ventilated area where there is no fresh air to dilute out those aerosols. So in a case like that, those aerosols are going to simply accumulate inside that space, and they will reach that threshold where they actually are infectious to other people. Now, I'm going to tell you about this one cluster of infections that from a restaurant in China, which was very well documented. It's going to teach us about this aerosol-based transmission and how it might apply to schools. So the story over here was that this was a Chinese restaurant around the time of the Chinese New Year, and this one person over here, A1, had just returned from Wuhan to another city, and went out for a celebratory meal with friends and family in this restaurant. The person was not symptomatic at the time. He was pre-symptomatic, and so didn't know that he was sick. But as we know, people who are pre-symptomatic or nonetheless can be contagious. And it turned out that this led to a cluster of infections in the people who shared the same table as this individual, as well as some people in the surrounding tables who were more than 6 feet away from this case patient, from this case individual. So the infected diners, in fact, were up to 12 feet away from the infected diner. Now, the interesting thing about this restaurant was that it had an air conditioner that was here on one wall, and it was blowing air from table C across to A, across to B, and it was bouncing off the opposite wall and coming back again to B, A, and C. There was no outlet, there was no vent, exhaust vent for the air conditioner. The exhaust vent over here on the opposite wall was closed. So basically what you had was a circulation of air in just this one area of the restaurant that was not being refreshed by any outside air. In other words, you can think of this as an extremely poorly ventilated segment of the restaurant. And that's what was felt to allow for the spread of infection beyond the classic 6 feet to the people at the other tables. They went back and did some studies on the air circulation in this restaurant using a tracer gas, and were able to reproduce the pattern of flow of air inside this restaurant. And what you can see over here is that in the back part of this restaurant, there was basically just the air in that segment of the restaurant was basically fixed. It was simply just recirculating that same area again and again, and not being diluted or spread out amongst the rest of the restaurant. So it turned out that people who were in that area of the restaurant, 9 out of the 20 people there got infected, so 45%. However, that restaurant was full. There were an additional 68 people on that same floor who were also eating in the restaurant at the same time, and not one of them became infected. Now, again, they're in the same airspace, but they're not in that one zone that's being dominated by the air conditioner, leading to no air recirculation. So the message over here is that if you're in an area with very poor circulation, the risk of infection actually is pretty darn high. However, there's a limit to how far those aerosols will spread, that even though the rest of the restaurant was connected, was in the same airspace, not enough virus was diffusing beyond this one back part of the restaurant to infect those other people. So there's actually a limit to how far this aerosol-based transmission can go. It's a problem in a poorly ventilated area. It's not a problem in a well-ventilated area. They were actually able to characterize the amount of circulation of air inside this restaurant over here. In the back part, they estimated there were 0.7 air changes per hour. To give you some sense of reference, in our hospital, we have a minimum of 6 air changes per hour, so about 10 times as much air circulation as compared to this restaurant. And I say we do not see a problem with aerosol-based transmission inside of our hospital. So again, it's a demonstration of both of the capacity for aerosol-based transmission, but also the limits. Finally, I want to just share with you some very interesting visuals over here about the power of the mask and the fact that the kind of mask you wear matters. So check out this video over here. There's a video of people sneezing. Over here is no mask, cloth mask, 1 layer, cloth mask, 2 layer, surgical mask. Here the sneeze goes. Lots of secretions over here. See, cloth mask, single layer, lots of secretions get through. Cloth mask, double layer, not much gets through. Medical mask, not much gets through. Message, masks work. They do stop these secretions very effectively, but there are 2 caveats. Number 1 is that you have to have a good quality mask. From the cloth mask area, that means it has to be at least 2 or 3 layers, or a surgical medical mask. Number 2, you have to wear your mask right. So if you're wearing your mask like this below your nose, that only does half the job. It's like trying to keep your bathtub dry by turning off the faucet but leaving on the shower head. So you got to have your mask over your mouth and your nose for it to work. And here's just one final demonstration. Here's no masks. Here's our sharing of shared air. 1 mask, but 2 masks shuts it down completely. So remember, I wear my mask to protect you. You wear your mask to protect me. And together we are able to be much safer. Okay, I'm going to stop over there, and we spend the rest of the time taking questions and seeing what we can do together. Thank you.
Thank you.
That was great. I learned so much, and I'm sure there's questions, Lilia.
Yes, absolutely. So let's get right into it. Our first question is, what should we expect to look for regarding updates to ventilation for school buildings for safer in-person education?
Yeah, great. So I think, as we allude to, ventilation does matter. And that if you have very poor ventilation, say, imagine a scenario, a classroom with very poor ventilation. Say there happens to be one kid who has silent COVID inside of that classroom. Because kids tend to be in the same classroom for hours and hours, that is the kind of scenario where those virus-laden aerosols could accumulate and get to the point where they are actually contagious to other people. So ventilation does matter. Now, the thing is that ventilation is not something that you can guess at or extrapolate just by sort of gestalting a classroom by looking at it. In my opinion, it has to be professionally assessed by somebody who knows what they're doing, who understands the mechanics, the engineering of airflow, and is formally measured. And so what I would look to from my school is to say, first of all, do they believe this is an issue? I mean, that's the most important thing. If they blow this off, that's a big problem, and I would not send my kid to a school like that. But I think the schools actually are being quite attentive to this, and I want to know, what have you done in a formal way to address this issue? So have you actually measured airflow inside of your classroom, and does it meet the standards that are being proclaimed for the industry? And if you do not have enough airflow inside that classroom, there are well-defined strategies to mitigate the risk. So your options are, you can get a new HVAC system that does have better airflow. You can open windows and actually install fans to improve the quality of airflow, but again, that has to be professionally assessed. You can't simply assume that because you open a window that you've solved the problem. So you don't need to make sure it's done appropriately. You can add filters into the classroom. So a HEPA filter, for example, that'll literally suck those aerosols out the air so that they're no longer able to accumulate and infect people. So that's an option that a school can use. You can also install UV light. And what UV light will do is it will basically kill the virus as it's suspended inside the air. So that although it's still there, it is no longer infectious to people. So basically, what I would want to hear from a school is, have they thought about this in a deliberate fashion? Have they evaluated this had this evaluated by a professional? And what is their mitigation strategy? And if they can put together a good story that really hits those 3 items, then I think I would be okay.
Great, thank you. A couple of follow-up questions to that. There's a lot of questions around ventilation. So if a building has poor ventilation, for example, oil heat or no deliberate intake of outside air, is there anything that can be done other than open windows, especially here in Boston, that doesn't work so well in the cold weather?
Right. So those are the other 2 options I was mentioning before, which is that you can install filters. And again, this has to be done by somebody who knows what they're doing. You have to have a HEPA filter that has the appropriate capacity for the size of the room that it's in, right? So a little baby HEPA filter that's designed for a tiny one-person office is not adequate for a 20-person classroom. So you got to have the right kind of HEPA filter. Or again, you can use UV light to disable, to basically kill the virus that's inside the air.
UV is ultraviolet, right?
Yeah, thank you. Ultraviolet light, thank you.
And if a parent is concerned about school ventilation, do parents have the right to access documentation of testing the school has done? And if so, what's the terminology of HVAC testing that should be done?
Okay, so this one I'll pass on to Julia because it sounds like a legal question to me.
Well, the last question I'm going to pass back to you, but the state has made it very clear that school districts should be in close communication with families. And if you have any questions about safety and specifically about ventilation, then it is completely appropriate to ask those questions. And as Dr. Klompas was saying, to make your decision based on the answers you get and how they've, if you're concerned about ventilation, it sounds, let me say it back, like what he's saying is it's completely reasonable to ask the question. You can make your judgment based on how they answer it. It's clear that they understand that this is an important issue to address and to be evaluating, and then to learn from them what they've determined about your child's school and how they've addressed it. So is there there's certainly a right under there's certain legal rights that make it so any member of the community can have access to certain public information. But before you went the legal route, I would say to just write to your superintendent or your school committee chairs and ask the questions. And if there's any difficulty getting the answers, that's the kind of thing where you could contact our helpline about. It sounded like there's also a question about how to frame the ventilation specific question. Was that at the end, maybe a Dr. Klompas question?
Yes, it's about the terminology to use. What's the terminology of HVAC testing that should be done if you're speaking to the school?
Yeah. So it can be characterized in two ways. You can look at the air changes per hour, and you can talk about the cubic feet per person. Or the number of liters per minute. So basically some quantification of the airflow inside of the space. I'll tell you that it's not clear exactly where the boundary lies between good and not good. So there's some extrapolation that has to take place in the space. I can tell you that 6 air changes per hour is more than adequate, and that less than 1 air change per hour is inadequate. If you're somewhere in between over there, it's probably okay, but I don't have a clear sense as to exactly where the dividing line will lie.
That's part of the uncertainty you were talking about at the beginning, that it's on one end or the other, you may have clear answers, in the middle you don't, it's less clear.
Right.
Is that right?
Correct.
Okay, and you might have answered this already, but are room air purifiers effective?
If it's the right kind of purifier, so it has to be, first of all, adequately sized for the size of the room, has to have be able to basically filter the right amount of air so they can affect the equivalent of multiple air changes per hour. And it has to have the right kind of filter on it, a filter that's fine enough to be able to take out the virus. So a HEPA filter is certainly fine. A HEPA filter is actually a very high grade of filter. You don't need to have that good. The way that filters are measured is something called MERV system. And the minimum MERV that's felt to be adequate for getting rid of the virus is MERV 13 or greater.
And you can see from the results of the poll, at least, what the families here tonight are saying at this time. And we realize that a lot of you don't have all the information you need to make your final decision, even though you've had to make preliminary decisions. It looks like a third would lean towards in-school learning full-time if it was offered. A little less than a third would feel like their child should stay home full-time, and a little more than 40% would want some mix of in-school and home. And I think most families that we're in touch with are really waiting to get more answers from school districts to know when and how the choices are going to be available, and to get some of their safety questions answered.
So now moving on to transportation, we have a question. what would be some concrete recommendations regarding transportation? Would it be reasonable to ask that kids who share a van are from the same program or school rather than mix them all together?
Great, good question. There's basically two concepts I think that are inside of that very good question. One has to do what's the risk of transmission on a bus or some other shared form of transportation, and the other is what about this pod concept or this cohort concept? How does it come into play in general, and how does it apply to transportation? So let's talk about the first aspect first over here, which is what's the risk of transmission on a bus. So as before, the risk of transmission is a function of proximity, so basically the intensity of contact or proximity to the case patient, and duration. So if you're talking about a very short bus ride, say 5-10 minutes, then the risk of transmission overall is going to be extremely low. If you're talking about a longer bus ride, then you're going to get into this issue again of ventilation and of proximity. So I'd say that at the very least, you want to de-densify the bus, at a minimum cutting down the capacity to one kid per double seat, or 50% of normal capacity as a maximum, so that there are fewer people present, and so that kids can be more spaced out. And then we're also going to have to pay attention to this issue of ventilation if it's going to be a longer bus ride, because if it's a very poorly ventilated bus, meaning all windows closed, recirculation of air only, then we're going to get into that poor ventilation situation like we've been speaking about, where that could be a risk for contagion. So I would say that if you're able to de-densify the bus, you can cut down the capacity to at least 50% or less, and assure good ventilation by either opening all the windows, then I think that you would be able to make the risk of that bus ride actually pretty low. Now, can this be done in the middle of winter? I think is a fair question, like you, I guess I would worry about that scenario, and I think one would simply have to see. It might be that we're going to be wearing our jackets on the bus, and the windows are open, and the heating's going full blast, and sort of hoping that combination is tolerable. It might be that somebody's unrealistic, and that you cannot do that inside Boston in the winter, and therefore your strategy in the depth of winter or on a very cold day might be different from your strategy during the warmer months. The other concept that was alluded to was the notion of pods or cohorts. And the idea of pods or cohorts is that if you put kids into fixed groups that are relatively small and that stay together the entire time and do not mix with other groups, that should one of the kids in the group become infected, you've limited the total number of people that can potentially have caught the infection from that kid. It would just be the other kids inside of that pod, not the entire school, not the entire grade level. And so the idea of pods is to try to limit that mixing between groups, and therefore limit the amount of potential spread that takes place if there does happen to be an occult case. So should you embrace that pod concept on the bus as well, and or on say it's carpool or whatever it is that you're doing to get your kid to school? In the ideal world, yes. But we're not living the ideal world. So if you can achieve that, that's fantastic, and that's go for it. But if you can't, like everything else with going to school, we have to make a realistic decision about compromise. The entire notion of going back to school, I have to say, is ultimately a compromise, right? It's a compromise between two very compelling alternatives. On the one hand, we know that keeping kids at home is detrimental. It's detrimental for their learning, for their social development, particularly so for kids who have special needs. It impairs sometimes the function of the family. We know there's been a rise in child abuse. We know that sometimes prevents parents from being able to go to work, and if you have no money, then there might not be food to put on the table. It's an extra stressor. So there are all these sort of downsides to keeping a kid at home. On the other hand, I can more or less assure you that as kids go back to school, that although we will all try our very best to prevent infections, there will be infections. There is no perfect solution over here. There will never be a 100% safe scenario anytime you're bringing people together. And so what we're doing is weighing those risks of the downsides, the consequences, the cost of keeping a child at home for both the child, their family, and society, against the risk of infection, the child, their family, and society. And as you try to weigh that balance, two sort of very compelling sides, that story over there, you could imagine how different answers are appropriate for different families, depending on their particular factors. So first of all, what is my kid's need for in-person education? Right? If I have a kid who's actually doing okay via Zoom, and my family is able to keep that kid at home safely and happily, and I can work remotely from home without too much detriment to me, okay, so that's a very nice, safe option. You go for it. Now, by contrast, if in my home I have, say, a vulnerable person, an elderly person, a person who has a weak immune system, a person with underlying lung disease, who's at risk for bad outcomes if they catch COVID, and my kid can't, then I might be more prone to keep my kid at home. So I think you need to weigh the particularity. If you have a kid who's going to do fine by Zoom, keep them home. If you have a kid who's going to really suffer from that kind of educational approach, and you don't have any particularly vulnerable at home, that might be the kind of kid who's a good kid to go to school. And it might vary as well by your community. Somebody who's living in the North Shore right now, Lynn, Everett, Revere, etc., I think has a more difficult decision compared to somebody who's in Brookline or Newton, or in the western part of the state, where disease rates are much lower. So you really have to make an individual decision based upon who you are, your kids' needs, your family's situation, and where you live.
Really hard decisions for parents of kids with disabilities.
Yeah, I was going to say it's a tough decision to make. We're getting a lot of questions coming in. I just want to remind everyone, if you're on Zoom, we're sharing resources in the chat box. If you're on Facebook, we're sharing resources in the comment section, including information on how to contact our helpline if we're not able to get to your question today. Our next question is, when my child goes to school, do we need to all wear masks at home?
Because that's a good question. So first of all, let's just talk about masks inside the school, where if a person medically can wear a mask, it is critical. I think that there's no question in our minds that masks are effective at reducing the transmission of infections, although they're not perfect. So therefore, you can't rely on masks alone. You have to have the other important measures in place around distancing, which actually is the best protection, quality of ventilation, hand hygiene, small pods, etc. If your kid does go to school, should you wear a mask at home? So that's a difficult question, because it comes down to trying to find the balance between the perfect and the realistic. So I'll tell you that in my personal situation, I would find it very difficult to have to wear a mask 12 hours a day at home around my kids. I would find that socially difficult. I would find that personally uncomfortable. I would feel that it would be difficult for me to connect well to my child if they or I were wearing a mask the entire time. And so I accept the risk that I'm undertaking by still hugging, kissing, sharing meals with my children, despite the fact that I know that that's putting me at risk for infection and them. The calculus might be different if you have an older kid who maybe can understand why people are wearing masks, and you have a particularly vulnerable person at home who's at greatest risk of having bad outcomes should they catch COVID-19. Again, that's particularly the elderly population, people over age 70, 80 in particular, or somebody who has a weak immune system or underlying lung disease. In a case like that, maybe there is something to be said for trying to wear a mask at home, although again, you'd have to balance out the personal and familial toll if you were to choose to go that route. And again, that's a very personal decision only each person can make. So those are some parameters though to think through as you try to go about it. If you are wearing masks at home, I'd say it's really only important when you're close to other people. So for example, say the worry is that your kid might have acquired infection at school. You worry that they might pass it on to somebody vulnerable at home. So then you'd only have to wear your mask when you're around that child. But if you're at night in bed in a different room sleeping, you would not have to wear your mask at that time. It would really be only when you're close to your child. So being that's a tough thing.
Thank you. It's a nice segue into our next question. My son is on the autism spectrum and has asthma. Wearing the ear loop mask makes him have a hard time breathing. Therefore, he wears a bandana and does not have an issue with that. The school committee has said that bandanas and neck gaiters will not be allowed once my town returns to in-person learning. What's my next step to getting the schools to allow my son to wear a bandana? Can I have that written into his IEP? So that's maybe for both of you.
Yeah, so that's a good question. So I will talk about sort of the medical aspect of that, and maybe I'll pass to Julia the legal aspect of that question. It seems pretty clear that a single layer cloth mask like a bandana is inferior compared to a double or triple layer cloth mask or a medical surgical mask. It'll, without question, does allow more secretions through, and therefore does present a greater risk to other people if the bandana wearer happens to be somebody who has silent infection. So certainly the default is that whenever possible, we really should be wearing double or triple layer masks. Now, if you have a person who can't do that because of their underlying medical condition, of course, that's a different consideration. And I'll ask Julia to comment on sort of the legalities over there. But I think there are two perspectives on that. There's the child-parent perspective and the school perspective. The child-parent perspective is, of course, that you want your kid to be able to attend and to be safe. From the school perspective, the population perspective, it's a risk proposition to allow a kid under those circumstances to come into the school. And that of course, is the incredibly difficult and heart-wrenching struggle, balance that as usual, this virus is making us try to find. So Julia, what's your take on that?
Yeah, I mean, the state is very clear, and I think the laws are very clear that if somebody's unable to wear a mask because of their disability, then the child does not have to wear a mask. This district will then have to figure out how to make sure that there's, to address the social distancing and other issues to try to promote the safety of everybody. But the guidance has been very clear from the state that if a student is unable to wear a mask, which is true for many individuals with autism and other types of disabilities, then in the instance that they're talking about, then they would need to make that kind of accommodation to if the student can wear a bandana or whatever they can wear to accommodate their disability or their, as you said, their underlying health condition. So there should be no issue if the parent sends an email to their special ed administrator or their principal and explaining that it's because of the child's asthma that they need to wear the bandana, then they should make an exception. And if they don't, that's an excellent time to contact our helpline.
This next question, I think, relates back to a chart you had on one of your slides. If students are with their teachers and staff for just over 6 hours per day, 5 days per week, would that mimic the category of household members regarding the risk of infection from close contact for students with intensive special needs?
What a great question. So in terms of duration, that certainly would be getting to the same kinds of amounts of time that they might have with a household contact. The question though might be around intensity and closeness of contact. That might be different. So when you're at home, we share meals together with our family. We hug, we kiss. We are very close, and that's not the norm, of course, for a teacher to have that kind of degree of intimacy on an ongoing day-on-day basis. I understand, of course, for a child with disabilities that there might be more need for closer interaction. But in addition, though, there are the mitigation strategies that the school will be exercising as well, particularly around trying to have distance whenever possible, and of course mutual masking of both the teacher and the student whenever that's feasible. So I would say that on balance, it's probably not as high risk as sharing a household with somebody who's infected, but certainly a higher risk compared to a more casual encounter in, say, an office or a workplace. It is useful to reflect a little bit about what we have seen from schools around the world and around the country that have opened up, because I think that's another way to take a window into this question of how likely are schools to lead to clusters of infection. And what we've seen is that while there certainly have been clusters of infection in daycares and in high schools, there's actually been relatively little clusters of infection in elementary and lower level schools. the biggest group that's seeing large amounts of infection in the context of school reopening really is universities, colleges and universities. And that's thought to relate to the fact that even, this is the great irony, some of these universities are actually having remote-only classes, but are still seeing clusters of infections because kids are socializing outside of class. So the classes themselves are perfectly safe because they're online, but kids are still getting together, bars, parties, social visits, etc., outside of class, and that's leading to transmission. And of course, that need not be the case if you're talking about an elementary school child or a high school kid in whom you're exercising some degree of control of their out of classroom activities. So on balance, I'd say that in the classroom itself, if you're able to adhere to the basic rules of distancing, masking, and hygiene, then in fact the risk of transmission is probably on the lower end of the spectrum.
And embedded in that question also was for, I believe, just to answer the question, that for children and students with more intensive needs where they're going to need more close contact with the teacher or the paraprofessional, then the state has required additional measures with more protective gear for that teacher or paraprofessional to be using if they're going to be in close contact with the child. So again, I would assume that would make a difference too, Dr. Klompas, if they're wearing full protective gear.
No, absolutely, and I think the analogy would be inside the hospital, where we are routinely taking care of people with confirmed known COVID-19, and we at our hospital we've taken care of over 1,000. We've paid patients with COVID-19 every single day, cared for them myself, and our rate of hospital-acquired COVID-19 is incredibly low. And the reason, of course, is that we're using personal protective equipment and we have very good ventilation inside of those patient rooms. So if you are able to optimize the personal protective equipment equation and the ventilation equation, you can have close interactions with symptomatic people with COVID-19 and still be very safe. And the question is, to what extent is one able to mimic that inside the classroom, accepting that the classroom is different from a hospital, and therefore it's not under the illusion that you're able to perfectly mimic what we're able to do over here.
Great. Do we have time for what, one more question, or what do you think, Lilia?
Yeah, I think we've got time for one last question here.
Before we do the last question, I just wanted to note there was a poll earlier. I wasn't able to see the results, but asking folks for their ideas about different topics for the future chats. If you can also share your ideas in the Q&A about different things you would like to hear about or different types of speakers that you would like in the coming months, please share your ideas. Our next chat will be 2 weeks from now. And however, I did want to let you know and for you to share with other members that there is a group next Thursday night. There's a group called the Circle of Vietnamese Parents that will be hosting a chat that's provided in Vietnamese around the school reopening process and guidelines and strategies for parents to know about. So that information will be shared if you know any families who may want to be aware of that option next Thursday night. And we have our evaluation poll. And thank you so much, Dr. Klompas. We'll take your last question and then we'll wrap up.
All right. Our final question. What are your thoughts on the 6-foot rule in school versus the 3-foot rule? In many instances, the 6-foot rule makes it difficult to have all students in the classroom.
Yeah, so that's really difficult, but really good question. Masks are good, they're not perfect. And distance is really the most effective way to protect yourself. The 6-foot designation, the 3-foot designation, they're pretty arbitrary. There's no sort of hard biological rule why respiratory secretion should only travel 3 feet versus 6 feet, and as we saw together, can sometimes even go beyond. So the more space you're able to achieve, the better. Now that has to be balanced again with the practical realities of what a classroom can actually accommodate given the physical space that's present. My strong preference is to go for 6 feet whenever at all feasible. And if a classroom cannot accommodate that with the number of students inside the classroom, I would strongly advocate to find a larger space or to break up that class into smaller portions. again, I'm not have no illusions about that's easy to say and incredibly difficult to do. Might not be possible. The state requirement, as you know, says 6 is the ideal, but 3 feet is acceptable. But from a medical safety point of view, it is clear that more is better. So that I'm afraid will stay a dilemma.
Right.
Thank you. There's so many other great questions here, but we know it's late, and so I think we have to wrap up at this point. Please contact our helpline if you have questions that weren't answered. If there are questions that we need to contact Dr. Klompas about, I may email you to get some answers if there are things that you can provide somewhat briefly. Some of these are questions, they might be clear from the slides actually. Some of these questions I think will be clear from the slides when we're able to share those. So Dr. Klompas, thank you so much. We know that you are busy every morning, evening, and night working on many of these issues, and we really appreciate you taking the time so generously to talk with families and advocates tonight. And everybody stay safe and good luck in these few weeks before most schools are reopening, and we will see you in 2 weeks. I hope things go as well as possible in these unprecedented and unbelievably difficult times. Thank you, Dr. Klompas. It's been a huge...
Thank you so much for having me. Thank you.
Thank you.
Thank you, Dr. Klompas. Great. Good night, everyone. Thank you for coming.
Thank you, Vivian.